So I would first of all thank the organizer of this very interesting meeting, and in particular because it gives me the opportunity to review quality of life data, which I think that when we read literature are a little bit neglected or overseen. First of all, I would also say that when I went through this data, these papers, I found that chemotherapy, in particular quality of life measurement, only for patients receiving, let's say so, for patients receiving only chemotherapy are very poor. It's rarely, has been rarely measured only for patients receiving chemotherapy. Rather, this measurement has been done for patients either on treatment, on poly-treatment, combination treatment, or after treatments, poly-treatments. So the first point, the first question I asked to myself is why assessing quality of life in cancer research? First of all, quality of life has been regarded as an efficacy endpoint, similarly to survival, because if we want something from a treatment, we want either to survive or to have a good quality of life for the rest of our life. So this is considered, quality of life is still considered an efficacy endpoint. Then quality of life can help us in comparing treatment modalities. And this is true particularly when the outcome, survival outcome are similar, are the same. Then treatment comparison may be helped by assessing quality of life. Quality of life can focus rehabilitation intervention when we know that there are some impairment in quality of life. We can have appropriate intervention to prevent quality of life impairments. We can look at quality of life as a predictive or prognostic factor, and of course quality of life can be used to help patients in their everyday decision making. There are at least two assumptions. Functional impairments due to disease, treatment, or any late sequelae translate simply into a poor quality of life. The corollary to this is that any physical deterioration impacts on emotional well-being. So the disease-specific quality of life instrument, which has been used in quality of life measurements in head and neck cancer, are disease-specific, since it became clear from the very beginning that the spatial status of these patients needs specific quality of life instruments. These quality of life instruments are designed so that they have different characteristics, so that they can be used for different purposes in different phases of disease. In general, there are questionnaires for self-administration. They're made up of items for which patients are asked to respond. And finally, they provide a global score of quality of life. As I said yesterday, toxicity is not quality of life. However, if we look at late effects by treatment modality, there is a difference in terms of incidence and in terms of type of late effects as regards treatment modality. And this, in turn, will affect quality of life after this treatment modality. Surprisingly, late effects of some treatment modalities seems to be a little bit underreported. Also sites, tumor site, and the type of tumor, it means tumor volume, has an impact on functional outcome of patients. For example, you see here that oral cavity and oropharyngeal cancer seems to have, at least after radiation therapy, a poorest outcome in terms of diet and eating in public. Interestingly, when you look at patients in the mixed group, you lose sensitivity. So the message is we should look at functional outcome site by site. So going by looking at this literature, we learned that head and neck cancer patients suffer of a lot of functional and clinical impairments as pain, sexuality problems, cough, voice, eating, diet, aspiration, asthenia. But they also suffer from social problems like finances, employment, family, social activities. So I would say that in absence of this data, we would never have had the opportunity to get these informations. So in this sense, quality of life data helped us in understanding problems of head and neck cancer patients. So to go in the problem, I looked at and I was interested in seeing if pre-treatment quality of life is dependent on something or not. So looking at the literature, I saw that past medical history, so comorbidities and ASA score, can have an impact on pre-treatment quality of life. Interestingly, weight loss can be predicted by the baseline quality of life. As well, depression, performance status, and gender may have an impact on pre-treatment scores. Psychological, more than physiological factors seems to have an impact on health-related head and neck quality of life. There are interactions, specific interaction of patients' characteristics with global quality of life. This is a poorly understood, poorly explored area. However, it's very interesting. And the pre-treatment score predicts for the post-treatment value. And this is something that we have to keep in mind. Quality of life has been studied, of course, according to sites, to tumor sites. In particular, in laryngeal cancer patients, there were cross-sectional studies. It means that quality of life has been studied once in the natural history of these patients. And this is, of course, a pity because the ideal thing would be to have a baseline on treatment and after treatment at different times. What I saw is that there was a high variability in the purpose of the study. Importantly, the purpose of the study were laryngectomy versus quality of life of laryngectomy patients versus radiation therapy, or different type of surgery, total versus subtotal surgeries. Surprisingly to me, in most studies, global post-treatment quality of life was similar. There were some differences only in subscales. And this is a counterintuitive results of quality of life. We would have expected that quality of life of laryngectomy patients would be better than radiation therapy patients. This trial, the VA trials, was analyzed also by means of quality of life, and it found that there were differences among quality of life outcome, in particular on subscales. Quality of life, again, for laryngeal cancer has been evaluated in the, let's say so, in some next generation quality of life studies, surgery versus chemo and radiation. So there are 3 experiences. Summing up the results of these 3 evaluations is that most patients report excellent global health-related quality of life, and these are independent of the treatment they received. They offer us the opportunity to look at different quality of life impairments and functions after treatment. So chemo and radiation patients can be anticipated to suffer more of pain, difficulty in swallowing, chewing, dry mouth, as opposed to laryngectomy patients which have impairment in speech, shoulder function, social function, sensory disturbances, use of painkillers, and cough. So in this regard, quality of life data can help us in depicting scenarios for our patients. Interestingly to me, after surgery, disability, stress, and dysfunction was more important for oropharyngeal and oral cavity cancer than laryngectomy patients. Depression and anxiety was similar among the 2 groups after surgery. There were confirmation that there is a differences in terms of subscale outcome in surgery versus chemo and radiation. type of reconstruction was not affecting quality of life, rather speech, cosmetic, and swallowing. This is also interesting. There were reports of loss of confidence and uncertainty for the future in oropharyngeal and oral cavity cancer. What affects post-treatment quality of life? So treatment, in particular type of surgery, and the target radiation volume, it means that the difference in terms of treatment you get according to the same treatment, then you will have some impact on quality of life. Intraarterial chemotherapy was similar to what has been observed to systemic chemotherapy. Neoadjuvant was similar to adjuvant chemotherapy. Coping strategies, as we know from yesterday, affects quality of life. Speech, swallowing affects quality of life. In particular, patients have a better outcome in terms of quality of life with no postoperative radiation, and primary surgical closure were associated with a better outcome than reconstructions. Feeding tube, tracheostoma, neck dissection was affecting quality of life, and as we heard this morning, conflicting results were available on xerostomia in terms of affecting quality of life, of post-treatment quality of life of patients. This is an interesting paper by Mercy List on seminars on oncology. This paper was looking at the different outcome and quality of life of patients undergoing two types of, accelerated radiation, but it was a bifractionated radiation with hydroxyurea, or with the only difference between the two groups were cisplatin and taxanes. So I would direct your attention on the effects on treatment, comparing the two schedules. There was a little bit more toxicity, let's say, in terms of impairment, in terms of dry mouth, stick, saliva, and so on in the taxanes. Quality of life domains seems to worsen on treatment with taxanes as opposed to cisplatinum treatment. But when we go to the 12 months evaluation, quality of life of these patients seems to be better than patients undergoing cisplatin. It means that quality of life should be, this is important because it means that quality of life should be measured pre-treatment, on treatment, and after treatment before driving any conclusions. Results. In general, we can say that, and we have seen it also in the data that has been reported yesterday for the Bonner trial, QOL-F, deteriorates during treatment and slowly returns to pre-treatment values independently of the type of treatment. This is to me a counterintuitive result in some way. Quality of life has been reported as a prognostic factor, and what we know today is that quality of life depends also on several pre-treatment factors. Nevertheless, quality of life is poorly utilized for rehabilitation interventions. Quality of life scores are not utilized as prognostic tools, neither as predictive tools, and quality of life has been poorly explored within processes of shared clinical decision making. Why? Yesterday we took the point that probably quality of life instruments were too long. So are we dealing with poor quality instruments, or our problems are due to the fact that these are particular patient setting? But what are we really measuring? Is that we are measuring the adaptability of the human being instead of real quality of life? These are questions that I have not good answer for them. Then what we don't really know, and this is a poorly explored area, is how patients, head and neck cancer patients, prioritize treatment outcomes before initiating